My name is Buchbinder. I'm a melanoma medical oncologist at Dana-Farber, and I specialize in treating patients with melanoma kind of at all levels, work in immunotherapy, targeted therapy, new drugs, and toxicity. And so I am going to talk a little about some of the new exciting cellular therapies. And so if there's one message that you guys really will take from today, it's how much we as medical oncologists in melanoma and immunotherapists adore T cells. And I would argue that it's not just T cells. We like all lymphocytes. We like all of those immune cells that are going in there and attacking the tumor. And, you know, I think I have teenage kids, so I kind of think of them as like the Avengers of the immune system. They're going in and getting those bugs, getting those viruses, bacteria, but then also those tumors. And the good news is when you have a melanoma, that melanoma isn't just melanoma cells. And so what you can see here, these dark things, those are your melanoma cells, but there are also these green and blue. These are those lymphocytes. These are those immune cells that are actually in the tumor already. And very often they're trying to do the job. They're trying to get rid of that melanoma, but they're exhausted. They're trying too hard. They need some help. They need something to kind of keep them going. And immune therapies do that. So the immune checkpoint inhibitors, they really kind of boost them up, help them keep going. But those cells, those are really the powerhouse behind what we need to do to use the immune system to fight cancer. And so we've got a picture of a couple of those. You know, there's Thor and Iron Man getting that tumor right there. And so we need to do things to make those cells stronger. And what cellular therapies are doing is kind of not just working on making those cells stronger, but working on the fact that those are the cells that are the most likely to be able to attack that tumor. Those are the cells that are there. They know that that tumor, they're already trying, but they're kind of worn out and not able to do everything they need to do. And so the idea behind cellular, so using TIL therapy or tumor-infiltrating lymphocytes is actually trying to make those lymphocytes already in the tumor stronger and giving them back. And so there's several steps involved in this process. The first is actually removing a tumor, because within that tumor, it's got those lymphocytes, so that tumor is removed. And then after that tumor is removed, there's all sorts of steps involved in preparation and treatment of those lymphocytes in order to give them back to fight the melanoma. So surgical removal of a melanoma lesion, that lesion goes to the lab, so that tumor goes to the lab. The melanoma cells are killed and gotten rid of, and the immune cells are fed and grown. And so in the lab, those lymphocytes are grown up. They're given all sorts of food and, you know, ensure, boost, everything they need to get stronger, and are purified, they're treated, they're expanded. And then what happens is they're given, patients come into the hospital and they're given back to the patients. Now, there's a couple steps that happen before this happens. First off, the body sometimes reacts badly to immune cells when they're given back to patients. So a little bit of chemotherapy is given to kind of suppress the immune reaction that the body might have to its own immune cells. So that there's a little bit of chemotherapy that's given. Then those immune cells are given back. So those TILs that have been really fed and grown up are given back. And then following that, there's actually some additional therapy that's given, which is called IL-2. Now, if you remember when you were looking at Dr. Sullivan's slide, IL-2 was a therapy approved a long time ago for melanoma, and actually has some benefit on its own for melanoma. But what it really is it is that gas pedal. It stimulates those immune cells, all of the immune cells in the body, including those TILs, and can really get that immune system going and those lymphocytes going. And so what this therapy, there's many steps involved in this therapy, but the goal of this therapy is to really stimulate those lymphocytes that are already in the tumor, already recognize it, to then go out and fight the melanoma. And this is another kind of schema of the same sort of thing. What I thought was interesting here is you can see this process takes a while. So this is the tumor is removed, it goes to the lab. There's a whole kind of processing that happens. And here it's, they're saying 22 days before those cells are ready to go back and be infused into a patient. But very similar in terms of the different steps that, have to happen with tumor removal, patients getting a little bit of chemo to kind of set the system up for those lymphocytes to work, and then that infusion followed by that IL-2. And what's been seen with these therapies? So that this is data of a cellular product called lifileucel, which is one of these TIL therapies. And what was done is many patients with melanoma who progressed after other therapies were given this TIL therapy. And there are two cohorts here. It just happens they were run kind of one then the other, but really looking at this green column, there were 153 patients total that were treated with this TIL therapy. And what you can see here is that 31% of them had some reduction of their melanoma. And these are patients that had had many other therapies prior. And in fact, in terms of, there was also 46% that had stable disease. So their melanoma didn't grow, with only 17% really having progression of their melanoma after this therapy. So this is really exciting data, and really shows that this therapy can potentially have some very nice efficacy in patients who've had other therapies before and then are treated with this TIL therapy. What this is, and is looking at the side effects related to that therapy. And this is based on time. So looking at the bottom, and so D14 is day 14. Most of the side effects to this therapy also happened really early on. So they happened when patients were still in the hospital. A lot of them were from the chemotherapy I talked about, or from the IL-2 itself. And so that many of those side effects resolved. And over time, when you're out at month 1, month 2, so further out here, there were very little residual long-term side effects from this therapy. So it was pretty well tolerated. And this is, we talked a little about these waterfall plots. And what these are is they're showing this line at 0 is if the tumor didn't change, then patients stay near 0. Any patient on here where the tumor shrunk, it goes downward. Any patient here where it grew, the line goes upward. And so what you can see here is that a lot of these patients had very nice reduction in their melanoma with this TIL therapy. And so all of the blues here are those who had a partial response. The green are patients where their melanoma disappeared entirely. And so very exciting data in terms of what we're seeing with TIL therapy in melanoma. This is a complicated figure. I think I could hang it on my wall. It's so pretty, but what it is showing is the different lines of therapy that these patients had before going on TIL therapy. And you can see out here, there's one patient that had 10 prior treatments before going on TIL therapy. And so what it shows is that this is a therapy that can be used even after other therapies, other immune therapies, other targeted therapies. So the red line here is targeted therapies, most likely BRAF targeted therapies. The green line is green lines are immunotherapy combinations or immunotherapy with targeted therapy. And you can see that many of these patients received many different therapies before going on TIL, and yet we still saw a pretty good response in all of the patients that were treated. So this is really exciting in terms of the fact that TIL is therapy, because it can be quite hard with the chemo and the IL-2 after, is something that could even be done after other therapies and still have some benefit. In addition, what is really been seen with these TIL therapies is that when patients respond, that response continues. So we think of this in terms of duration of response. So if something works, but it only works for a month or two, how excited are we about that? Probably not so much, but if it works and keeps working, so it keeps the melanoma from growing like a lot of our other immunotherapies do, then that really gets us excited. And so with TIL therapy, that was another thing that was seen, is that in patients who responded well to it, it continued to work. And so that's very exciting. Now, the big question with TIL therapy, though, is how does it compare to other standard therapies that we might be thinking about, so that we can think about, when do we do it? How do we treat patients with it? And in all of the studies I showed you so far, or the data I showed you so far, it was just everybody was treated with TILs. There was no comparison. And so most of our trials are done where we compare it against something else. And so in this case, this trial was done that was comparing TIL therapy versus ipilimumab in patients whose melanoma had grown after receiving PD-1 inhibition. So either nivolumab or pembrolizumab, and then needed another therapy. Their tumor didn't respond to that PD-1 inhibition. This trial randomized patients, so half the patients got TIL therapy, half the patients got ipilimumab. Now, of note, you've heard of us talk a bunch about how these days we're mostly using combination immunotherapies. This was a trial done before that was done as much. So most of the patients did just receive one drug. But what was seen is that in those patients who received TIL, so this is this red line, that they did better than those patients treated with ipilimumab alone in terms of the time to their melanoma growing. So you've been looking at a bunch of curves with the adjuvant therapy that are looking at recurrence-free survival. So how long until the cancer comes back? And every time someone's cancer comes back, that curve drops a little. This is how long until the cancer grows. And unfortunately, we've still got a lot of work to do, but what it shows is that TIL therapy in this setting can be better than ipilimumab. So in the second line setting, can improve upon the growth of that melanoma. So this is the responses, and here you can see that there was so the response rate was 48% in there, 49% really in the TILs, and 21% in the ipilimumab treated patients. And once again, here are the waterfall plots showing quite a few more responses in those patients treated with TILs as compared to those treated with ipilimumab. And so this study really kind of established that TIL is potentially a great therapy after frontline immunotherapy. And hopefully it will be something that we see actually entering into our standard of care in the next many months. Unfortunately, the FDA actually, so the lifileucel, the first therapy I showed you, that was up for FDA review and got delayed. It was supposed to be reviewed by November. They just delayed that back to February due to staffing issues. So hopefully this will be coming. There are many clinical trials of this, but definitely an area where we're super excited to be working and super excited to be hopefully soon being able to offer this as a therapy in melanoma. Now, there are also a lot of efforts, and I really just put this up as kind of a placeholder to talk about. There are tons of efforts trying to make these TIL therapies better. So we talked about how, we're taking them out of the body. These are the lymphocytes. These are the fighters. What this is doing is trying to give them a stronger weapon. So give them something on the surface that's going to make them better, make them work even, better against the melanoma with all sorts of new technologies. And so this is one company that's doing this with CRISPR, which is this new scientific technique where you can alter cells. But there are many companies out there that are doing all sorts of things to try and make this happen. And so TILs, place to watch, hopefully approved within the next, now I guess we're looking 6 months, but also an area where we're going to see a lot more work done because there's going to be efforts to make these better and make these stronger. So CAR T cells came up, and I smile because I do have a couple slides about CAR T cells. As Dr. Ott mentioned, still too early in melanoma. We don't have any CAR T cell therapies yet, but I do hope that maybe we will. But I wanted to talk about what is a CAR T cell, because a lot of people hear it, they're asking what it is, and so I want to explain what this is. So CAR stands for chimeric antigen receptor. And so this is part antibody molecule, part T cell activating molecule. And so you've heard a bunch about how there are different things that activate the T cells. And you heard from Dr. Sullivan about these bispecifics that kind of bind, that have signals that kind of pull in the T cell. Here, that signal to activate the T cell is actually within this molecule. And there is a thing on the surface that allows that T cell to then recognize something specific on a cancer cell. So basically a honing mechanism that's put onto that T cell so that it can then recognize cells that are abnormal. Now, you can see here, there's all sorts of different ways these are built up. And what is happening is that T cells are taken out. So T cells are taken out of patients, actually, in this case, not from tumors, but actually from the blood. Those T cells are treated so that they then have these molecules on their surfaces and then given back to patients. And so this is an area that has really seen amazing success in the hematologic malignancies and the treatment of lymphoma, leukemia, but is still being developed. There's still a lot to be done here before we can use this in melanoma, but who knows? We're hoping soon that maybe some CAR T cell therapies will be developed in melanoma. There's a lot of other ways that cellular therapies are being used, but these are some of them. So here is just a little bit about that CAR T cell. How is, what is it and how is it made? And so the T cells are collected. There is this transfection technique where DNA is given into the cell so that that T cell itself then produces this CAR protein on its surface, and then that's given back to patients. And here are a couple pictures of what some of these look like that have been kind of approved or being used now in patients, all in large B-cell lymphoma. But this is Yescarta, which is one of the ones that's approved, Kymriah and Lysocell. So these are CAR T products that are currently in use and have been shown to be really effective. And so I'm not going to go through this, but just in lymphoma have remission in about 40% of patients. So really, really exciting. One of the issues with any cellular therapy, and also in particular with CAR T cell therapies, is that there can be a fair amount of side effects associated with this therapy. So there's something called cytokine release syndrome, where when these cells are given back, they lead to such a robust immune response within the whole body that they produce a ton of these cytokines and lead to the body almost thinking it's fighting a really bad infection. We can see this with some other immunotherapies as well. And then also there are some issues with neurotoxicity where patients can become very confused on these therapies. So one of the biggest take homes here is that there is tons of work going on developing all sorts of different techniques and technologies within immunotherapy, and that these range from things like what we've heard about today, so the cancer vaccines. There's some work going on in cytokine therapies. What cytokines are is that IL-2, those things that kind of feed the immune system and boost it. So adoptive cell transfer. So this is what these TIL therapies are, is actually taking those immune cells and giving them back or altering them in some way. Immune checkpoint inhibitors are our traditional, the ipilimumab, nivolumab, pembrolizumab, atezolizumab, cemiplimab, these drugs that basically take off those brakes on the immune system and allow those immune cells to attack the cancer. And then there also is some effort in terms of using oncolytic viruses, things that will get in there and make the immune system think that a tumor is infected to really boost the response within that immune system. So what Dr. Ott referred to, which is when you have a tumor that doesn't have a lot of immune cells in there, getting them in there by kind of tricking it and making it think there's something bad going on. So tons of areas where we're developing new treatments, new technologies, and new things for melanoma therapy and for therapy for cancer in general. So with that, I am going to end.